All right, everyone. I think, hold on 2 seconds. All right, everyone. Sorry about that. We had a little adjusting here to do. My name is Jacki Haley. I'm the clinical section manager here at Two Rivers Public Health Department. I will be leading this. It looks like we have about 36 participants today. So thank you and welcome. Hopefully everyone can see my screen and we will get started. I don't want to waste anybody's time. All right, I'm going to take my camera off so you guys can focus. Okay. So today our goal is to ensure everyone is well prepared in the event of a measles outbreak. So while we hope such a situation does not arise, it is important to be ready and respond effectively if it does. We will be covering the following items on today's agenda. So I will begin with a brief overview of Two Rivers Public Health Department. Next, our Health Director, Jeremy Eschliman, will extend a warm welcome to all attendees. Then we will hear from Dr. Sydney Stein, State Epidemiologist with Department of Health and Human Services. Following that, I will provide a national update on the current measles landscape. And then our epidemiologist, Aravind, will present a local update specific to our region. We will then move into key recommendations for preparedness and response. And finally, we will conclude with some inspirational remarks from Dr. Brady Beecham, Two Rivers Health Department's medical director. So thanks everyone for being here and for your commitment to public health and preparedness. So this slide goes over our mission and vision. In short, what we want you guys to know is we are here for healthier communities for all. Our next slide is a general history of public health in Nebraska. So this starts from 1867, where Nebraska becomes a state and goes all the way to present day. Do note that on 2000, measles was eradicated from the United States. This is our leadership team at Two Rivers Public Health Department. So leading us is Jeremy Eschliman. He will be speaking here in a little bit. And then we have 4 managers. So we have Aravind Menon, who's our epidemiologist, Jacki Haley, who I am, clinical section manager, Jesse Valenti, our finance manager, and then Katie Mulligan, planning section manager. And finally, before we get into the nitty gritty, this is who we serve. So Dawson, Buffalo, Gosper, Phelps, Kearney, Harlan, and Franklin counties. We serve just under 100,000 for population and 4,626 square miles. Up next, our health director, Jeremy, will share a warm welcome and opening remarks.
Okay, thank you, Jacki. I want to start off, it seems like a very appropriate, it's a beautiful day outside in central Nebraska here, for those that haven't been outside today, but a nice quote to start us off with. It's attributed to Mark Twain, but history doesn't repeat itself, but often rhymes. And it just feels very appropriate here because, and as Jacki had mentioned, it wasn't too long ago, it's been a couple of decades, but our parents, for a lot of us, the generation for many of us now have no exposures to measles besides vaccination. So anyway, as Katie would probably say, get back to your script, Jeremy. So thank you for being here today. As your local public health department health director, I want to begin by emphasizing that measles isn't just a childhood disease or a problem somewhere else. We're seeing this really grow as far as the level of contagion across the United States. Measles is a highly contagious virus, and it can spread rapidly, specifically in unvaccinated communities, and those are at increased risk. This meeting today is really about protecting all of us, our youngest, our elderly, those with weakened immune systems, and even those that maybe have been vaccinated, but for whatever reason, usually genetics, the vaccine isn't exceptionally efficacious in them. So to put this in perspective, we talk in epidemiological terms a lot in R naught. R naught is the reproductive number, and you've heard about this probably through COVID. This is talked about a lot. It's for every person that's infectious, how many additional people become communicable from that disease or get sick from that disease. So measles is, we always reference like it is the highest of any respiratory diseases. The R naught's between 12 and 18. That means for every one case, you typically get 12 to 18 additional cases. It's faster than COVID-19, faster than our seasonal flu, faster than Ebola. Because measles is so contagious, it often requires a very high level of immunity. I'm hoping that's stealing thunder from our subsequent speakers. But when we're talking about a herd immunity threshold, we're talking about 95%. That means if we take 100 people, or in our case, 100,000 people, that's pretty synonymous with our district, we would need 95% of that, 95,000 people to be immunized or naturally immune or whatever to prevent further spreading of measles. And as we know, and Dr. Menon will speak about this in just a second, some of the local data and statewide data that we have, it's challenging across the whole United States right now, and that's why we're seeing this outbreak is just seeing a lot less vaccination of something we previously thought was, wasn't a major concern. So when we think about vaccination, it's easy to frame it as a personal choice, and then of course to assign blame. But as we have several clinicians on the call, this, but we also know this in public health, we really look at this through the lens of population risk. It isn't just about one person's decision, deciding not to vaccinate themselves or their kids or their family, but it's about all of us. And so this isn't about blame, but it's really about how do we stop this transmission before it starts. And now at this point, we haven't confirmed any measles in our district, nor in the state of Nebraska. But we're monitoring, we're coordinating with state, local agencies in that regard because we think it's likely to happen and not too distant future. So it's in Kansas and Colorado, a few other places. So and as we know, with a lot of sorts of diseases that are respiratory nature, all it takes is one person. It takes one person traveling to some place that maybe they don't know they had an exposure, which is often the case, bringing it back to a population and then spreading from there. So today, really we hope this is a great venue for us to have a conversation about this for our community, and just give you more information on what to look for symptoms. Many of our clinicians that are currently practicing have seen no confirmed case of measles historically because it's been so long since we've seen this. But we also want to give you the information you need to know how to protect yourself, your community partners, your communities, both big and small. And so when this is a concern more locally, that you'll be prepared and you'll have credible knowledge. So our goal is to stop this before it starts. But there again, we want to make sure you're prepared. We answer any questions you have from credible information. So I'll stop there, and I'd like to, if you can go next slide, Jackie or Katie. I have the great honor of introducing Dr. Sydney Stein. Dr. Stein is the State of Nebraska epidemiologist. And I don't want to steal any of your thunder, Sydney, but been in the job for a little while now. Let's say that, and I'll turn it over to you.
Hi, and thank you, Jeremy, for the very warm welcome. I have been in the position. Tomorrow will be 1 month officially, so this is pretty new position for me, but I have been with the state since about July of 2023, just in a different role at DHHS. And wasn't necessarily on my bingo card that measles would be the first thing I was addressing when I took this job, but this is where we find ourselves. And so I want to be here to answer questions that you all have. I know we did a press conference at the end of last week. Hopefully you saw it. We really wanted to come out with a strong message that the MMR vaccine is both safe and effective, and that we didn't want people to wait to be getting those vaccines after we already have established cases. Now is really the time. Katie, if you could go to the next slide.
Jackie, that's you.
Oh, sorry. um, okay, so Jackie, if you're going to talk about the national update, that's fine. I thought that one was mine.
All right, sounds good. Thank you, Dr. Stein. And if you have anything that you want to add at any point in here, just feel free to break in. All right. Okay, so we will go next up to our national update. So currently, as of April 10th, there has been a total of 712 confirmed measles cases, and these are reported by 25 jurisdictions. So I like the map because I'm a visual person. So you can see, Texas, obviously, but Oklahoma, Kansas, it's starting to creep up closer to Nebraska. So that is why we want to be prepared and, everybody to be knowledgeable. So of the 712 confirmed cases in the 25 states, the most affected ages are under 5 years old, and that 5 to 19-year-old. So those two categories combined is 70% of those 712 cases. So that is where the most cases we're getting. Vaccination status, so 97% of those 712 are unknown or unvaccinated. And 1% have received 1 MMR dose and 2% received 2 MMR doses. Hospitalizations, so there's been 11% of cases hospitalized, so that's 79 cases out of the 712. And then percent of age group hospitalized. So we've got the most hospitalized right now are under 5 years of age, so 20% of the under 5 years have been hospitalized. And from 5 to 19 was 7%, 20 years old and older, 6%, and then there's a 13% that's unknown right now. And then to, leave it with a bang, I guess, we have had 3 deaths in 2025. 2 of them have been confirmed and 1 is still under investigation. So that is our national update. So now we will hear from our epidemiologist, Aravind, who focused on the data and current status within Two Rivers Public Health District.
Thank you, Jackie, and hello, everyone. Just to follow up from where Jackie left off and to segue into local data, we are now at a stage when we can credibly compare the outbreak in 2025, and it is a full-blown. We've had 7 outbreaks across the country this year, and when we compare it to the outbreaks that we've had last year, there are some dramatic trends that are very clear and that can be observed on the screen in front of you. As you can see, the total number of cases is roughly about 3 times or so right now, and we are only in April for measles cases this year as compared to the entirety of last year. Last year we had a total of 16 outbreaks and 0 deaths, and this year we have had 7 outbreaks so far. And 93% of all of the cases that have been detected this year, so 93% of the 712 cases have been outbreak related. And this is kind of important. Last year, that same number was about 69%. This is important because this really feeds into the problem of having outbreak-based cases repeatedly come up again and again. It means that endemicity is probably already established for measles right now in the United States. And that really puts us in a different era, one that we have not inhabited for the last 25 years. Hospitalization rates this year is a lot lower than what they were comparably to last year. Again, all of these, the spread of the ages of the patients this year have been more about, there's been a greater percentage of people in that 5 to 19 age group, so kids who are not just under 5s, not just infants, as well as hospitalizations also. The spread is roughly about similar, again, 5 to 19-year-olds account for slightly higher proportion of vaccinated people, and also of hospitalized people. And vaccination status is also, you see that a lot of the people are unvaccinated, or we don't really know. What we're seeing is that the outbreaks are becoming more established year to year. What's also important to note is that an outbreak is what we call 3 or more related cases of measles that occur in a geographic area over time, and the cases have to be related. And so, 3 or more is an outbreak. If you have an outbreak for a year-long period, if it's a continuous outbreak for a full year, then the country is no longer is declared as no longer eliminated, measles eliminated. The United States had eliminated measles in 2000, as Jackie had mentioned, and it's only a matter of time. Now it's more a question of when, not if, we lose that status and we go back to essentially talking about measles as endemic in the country, rather than for it to be just just an isolated case that was maybe imported from somewhere outside. So this really does put us in a new era from this year onwards. Next slide, please. So one of the problems that we do face with local vaccination data is that in Nebraska, it's really very difficult to be able to assess what vaccination status, particularly MMR, is at the local county level. We really have estimates for the entire state, which use a somewhat representative sample of minors, of children, both children who are in kindergarten as well as children who are in 7th grade. And so the data that we get is we do statistical modeling to base data that comes from the National Immunization Survey, which is more like a passive survey that is conducted across the entire country, and then the Nebraska Child Care Facility Survey and the school survey. The Child Care Facility Survey looking at kindergartners, and the school survey that looks at 7th graders. The participation is voluntary and tends to be patchy, tends to also change with the capacity of the school and the bandwidth of the school to be able to respond and to participate in these surveys, as well as fundamentally misses out, especially the 7th graders, fundamentally misses out on a very key component that might be at higher risk, namely homeschool children who, might not, who are not part of the denominator or the numerator. So I want to put that out there before I discuss the data, just to sort of have the caveats out there, and for people to understand that that's what we're talking about when we talk about vaccination rates. MMR vaccination rate for 2024 for Nebraska is 93.5%, which is still is lower than the national average, and obviously lower than the 95% cutoff that we've established is best to allow herd immunity to exist. Next slide, please. So, using that data representation, how we represent vaccination data for children usually looks at these 4 vaccines. And this is from the DHHS own legislative update that was published in December of 2024, December of last year. I put the graphs in. I know it's quite messy. There's a lot here, and I apologize for making it so cramped. But and the suggested citation is at the bottom for anyone who's interested in going back and looking at the source document. But why I put this up here is to try and see, to show you across the years how vaccination rates have changed for some key vaccines, and how, as clinicians, it's important to think about childhood vaccination as essentially 2 separate set of events. And the first set of events that happen in the first 6 months or so of life, at ages of 2 months, 2 months, 4 months, and 6 months, when children have a bunch of vaccines, but mostly the ones that we measure are hepatitis B and polio. And then we look at varicella and MMR, which is at 12 months, so it is separated from that by about 6 months. It is quite conceivable that for a single mother, for a young mother, first-time mother, that the realities are significantly altered between the times at which they choose to access these vaccines. So while hesitancy is a big part of the discussion, I also, as clinicians, I think we must be mindful that, I hope that our partners are mindful of the reality that that these vaccines and access to these vaccines are separated by time, and that it presents for us and an opportunity to intervene in case of young mothers as well as people who might otherwise be too busy and who might forget this vaccination, this vaccination behavior in between. As you can see across the years, the rates of varicella vaccination have increased steadily across the years, but MMR has been showing a drop. The drop has not been marked, but you can see particularly in the kindergarten. Particularly, sorry, in the seventh grade vaccine coverage rates, MMR has shown a slight drop across the years, and this is something that is worrying. We also understand that COVID has had a lot to do with these declining trends of vaccination in general. Next slide, please. So with all the caveats that we have mentioned, we tried to look at specific data for our counties, looking at school vaccination data. Again, we're looking at student immunization in TRPHD for kindergartners as well as for seventh graders. And again, I apologize for how messy it is, but the graphs, each cluster of 4 bars represents one county, and it looks at for the same year, that is for the school year 2024 to 2025, it looks at the vaccination rates for each of these vaccines. So the first two are DTaP and either at kindergarten and then second at seventh grade, and then the blue are MMR for kindergarten and at seventh grade. And as is expected, you do see in MMR a slight jump that happens from kindergarten to seventh grade. You would expect some amount of catch-up that exists at that level, but you do see in tetanus and in Tdap, the rates have actually dropped. The vast majority of the people who've really not vaccinated, children who've not been vaccinated, have religious exemptions. Medical exemptions are about 1/6 of religious exceptions for the whole period of the year. The ratio was roughly about 120 or so medical exemptions and about 700 odd religious exemptions, and that seems to account for a vast majority of the children who are not fully vaccinated for both of these vaccines. The data incompleteness is one of the issues that we struggle with, but we're trying really hard to be ahead of this and to be forewarned. I think all of the messages that the administration is putting forward about vaccination are spot on, and I'm hoping that we are untouched in this wave of measles case outbreaks. Over to you, Jacki. Thank you.
Thanks, Aravind.
And Jacki, this is Jeremy. Just for a second, I'm not sure if Dr. Stein's able to comment to this, but from a statewide level, you know, as we're looking at this just from Two Rivers perspective, how do we fare with state data as far as in other local health departments? I'd be curious to know just your perspective.
So overall, Two Rivers is actually one of our higher vaccine coverage health jurisdictions, and so that's actually good news. You'll notice there is one county left off of here, and that's specifically because very low student population, and because this is a public forum, we have provided that data to Two Rivers Health Department, but the numbers are so small that that's typically like a suppressed value that we would not report back in normal years. So overall, the jurisdiction is sitting exactly kind of where we want them. We realize that not every student in every school is going to be vaccinated. We do allow for an exemption process, but I'm very encouraged that we have this. We have a couple other jurisdictions across the state that are actually below 90% across the jurisdiction, which is, or the county, and that's very unfortunate. And so we are sort of working in those areas to determine, what are the hesitations that parents might be having? Are there access issues? It's not necessarily wanting an exemption, but having access and being able to go and get your child vaccinated on time. So those are things we're working to address, but actually, Two Rivers is in a good position.
Yeah, that's fine.
Yeah, thank you very much. And I'm sure Dr. Beecham at the end of this presentation, she has opinions on clinical access. So not stealing her thunder. We'll continue, check.
All right. Thanks, Aravind. and Jeremy and Dr. Stein. So we're going to kind of move on into signs and symptoms. We'll go over our high-risk categories, prevention, and then kind of roles and responsibilities. So first off, signs and symptoms. So measles symptoms appear 7 to 14 days after contact with the virus. These symptoms could include high fever. It could spike to more than 104 degrees or above. Cough, runny nose, and or red watery eyes. 2 to 3 days after symptoms begin, you could develop Koplik spots. So these are tiny white spots that appear inside the mouth. Measles rash appears 3 to 5 days after the first symptoms, and it usually begins as a flat red spot that appears on the face and like the hairline, and then it spreads downward towards the neck, the trunk, the arms, legs, and feet. A small raised bump may also appear on top of that flat red spot, and the spots may become joined together as they spread from the head to the rest of the body. When the rash appears, the person may spike that 104 fever. Measles can be serious in all age groups, but there are several groups that are more likely to suffer from measles complications. So the serious health complications you're going to see in the children younger than 5 years of age, adults older than 20 years of age, pregnant women, and people with weakened immune systems, such as people that have leukemia or HIV infection. So common complications are ear infections and diarrhea. And then a serious complication could include pneumonia or encephalitis. So for prevention, this is what we can do right now. So we can do our routine MMR vaccinations, get everyone that can get their 2 doses of the MMR vaccination. Stay up to date with travel vaccines. So if you're going outside of the United States, make sure those are updated. And then also watch for signs and symptoms and act fast if we would, suspect or have a diagnosis. So if you do suspect or diagnose a patient, the first thing we want to do is isolate immediately. So patients with suspected measles need to ideally be in a single patient airborne infection isolation room. I'm not going to say that one again, so we're going to call that an AIR room, AIIR, or a private room with a closed door until you have an AIR room available. The patient should not remain in the waiting room or any common areas. So we want to get them secured and, isolated into that AIR room or a private room. We want to protect our healthcare providers by adhering to standard and airborne precautions. So we want to make sure whether we're evaluating a confirmed or suspected, we want to adhere to standard and airborne precautions. And this is regardless of their vaccination status. So if we have a suspicion, we're going to treat them and just, do your standard and airborne. Those without presumptive evidence of measles immunity should be excluded from work from day 5 after the first exposure until day 21 following their last exposure, and offered post-exposure prophylaxis as appropriate. Next up, we want to notify. So immediately notify your local public health department about any suspected cases. That way we can ensure rapid testing and get on the investigations. Next, we are going to test. So laboratory testing should be pursued for all patients with suspected measles. So the CDC recommends collecting either a nasopharyngeal swab or a throat swab for a reverse transcription polymerase chain reaction, or RT-PCR, as well as blood specimen for serology testing for all patients with clinical features. And then also collecting a urine specimen along with the nasal pharyngeal or the throat swab may improve sensitivity of the testing. Lastly, we're going to manage. So we're going to think about post-exposure prophylaxis or PEP. So Two Rivers will coordinate with the state health department to provide measles PEP to close contacts without evidence of immunity as soon as possible after exposure, either with the MMR vaccine, and we want to get that within 72 hours, or with immunoglobulin, and we want that within 6 days. So next up, we have responsibilities. So first off, I want to talk about state and local health departments. So what are responsibilities? So the local health departments, we have the lead in investigating the measles cases and outbreaks. So Two Rivers will immediately report those. Whenever you guys let us know, we let the state know. Because measles is a nationally notifiable disease. So it is of essence, time is of the essence, I guess I should say. So we want to get on top of it as fast as we can. We will conduct active surveillance. We will facilitate transportation of specimens to confirm diagnosis. We will enhance outreach and communications, we also utilize state-based syndromic surveillance to monitor. So we'll do all the follow-up and everything. So for clinicians, we want you to immediately report any suspected or confirmed measles cases. We always have clinicians on call. So we have an on-call number. Somebody's always on that. If it is not a clinician, we still have a clinician on call. So you will always get to someone here, whether it's night or day. So don't be afraid to call, and especially with measles, we'd rather have you call and it be nothing. So just give us a call. Also, no vaccination rates. So if it's a patient coming in, you want to know their vaccination status. If they are unvaccinated, you want to know, like, are they immunocompromised? Like, what's their medical history? Have they traveled? Have they been exposed or seen anybody that has, a positive measles case? So all of that information you want to know. The travel you want to know, is it in the United States? Is it outside of the United States? If it is in the United States, is it one of the states that's having a current outbreak? And then also, know the signs and symptoms to look for, and then just act fast, because the faster that we act, we can reduce this transmission. So for labs, so added this morning because thought about this. So for clinicians for lab, so you're going to need a viral transport media and swab, a sterile urine container, and then there's a form, it's called a VPD supplemental form. You're of course want to make sure that you label your specimens correctly. So last name, first name, date of birth, 2 bio bags, and then a category B shipping box and ice packs. So we do have the category B shipping boxes here. And like I said in the earlier slide, we will help facilitate transportation. And so if you let us know that you're testing, we'll make sure that you're testing correctly and that we can get it to NPHL quickly and effectively. So.
Jackie, if I could just add one piece here. So part of the reason that we're asking that all clinicians, if you're pursuing testing, contact the local health department as quickly as possible so that we can also be looped in at the state, is that currently we do not have measles testing in state. So it's either going out to a commercial laboratory, and we're seeing very delayed results with that, between 3 and 7 days, just depending on which commercial lab's receiving that. But through NPHL, we can can send up to the Minnesota Vaccine Preventable Disease, which is our regional specialty laboratory. So they have full in-house PCR, serology, and they can also do a type of test called Amoeba, which distinguishes between wild type vaccine and vaccine strain. So, we know that some kiddos after getting MMR within a certain amount of time could develop a rash and have, symptoms similar to measles, but it's just the vaccine. They're not contagious. And we don't need to put them sort of under precautions or keep them away from other people. And so that test can help us distinguish that. And we can kind of talk through the details. Part of our job at the state is to be very informed about where there have been various exposures in other states, airports, etc. And so we can help talk through that with the local health department if part of the travel history has anything concerning where we think they really could have had an exposure.
Awesome. Thank you so much, Dr. Stein. All right. Next slide I have on collection. So I will be sending this out to all clinicians as well. So there is a NPHL form that goes through all of this, and then the VPD form as well. So when I send you guys out the recording and whatnot, I will have a lot of attachments, and these will all be in there. So, and you'll also have our slides. But for collection, so nasopharyngeal or throat swab, so you need to use the standard NP throat swab technique. And then you need to place it in a viral media transport, secure the lid, label it with the patient name, date of birth, collection time, date, source, collector's initials, and then refrigerate. Urine, you're going to collect 5 to 10 mils of urine in a sterile, leak-proof container. Label that with the patient name, date of birth, collection time, date, source, collector, initials. Place in a biohazard bag and refrigerate. And both of them need to be in a biohazard bag. And then, like I said, you guys will be talking to us at this time anyways. And so we'll make sure that you guys have all this information. And then if you don't have pickup and whatnot, like we will organize all of this. So the key is just to let us know at the beginning and we will walk you through it. So for schools, because I know I have school administration on here as well. So what do you guys do, right? So immediately report any suspected or confirmed cases of measles. That's always going to be your top one priority for us. And like I said previously, Two Rivers always has somebody on call. So you'll always get to somebody. Know your school vaccination status. So personally within that school, if you have any kids that are unvaccinated, know that data. If you have kids that are immunocompromised, or if they have been traveling recently, whether it's out of state or in state, anything that would place them in that high risk category, that's the information we want you to know. Because when we do have, we're not going to say when we do have, if we would have an outbreak within your school, those are the things we're going to want to know, because those kids that are immunocompromised or are unvaccinated, we want them home. We don't want them to have any kind of access or, any way to get this, because it is very, very communicable. So that's the information you want to know. You want to know your signs and symptoms. That's why I went over it earlier. And then the main point that I'm going is not only to notify us immediately, but to act fast. That way we can reduce transmission. And then for the general public. So I know this kind of sounds like a little bit repeating and everything, but I have got a little bit of everything on this call. So I wanted to make sure that everybody knew their role. So first off, immediately report to Two Rivers Public Health Department. We always have someone on call. I figured if I said this 3 times, everybody would know it, right? So it's going to be the same thing. If you suspect that you have someone that you know that has measles contact, you need to notify the doctor immediately. Make sure that if it's you or your family member, that you call the doctor's office before you go in and you tell them, hey, I think I could have measles, or hey, I think I had contact with somebody that had measles. because we don't want you going into the office, sitting out in the waiting room, and then, going into the clinic room. We want to talk to you on the phone, and then we'll advise you on the best plan. And usually that's going to be like bringing you into like an ER where they have that air room, or negative flow or something. But that way we're prepared and we can protect staff and we can protect all of the other general public. Know your vaccination status. If you do not know, you can look it up on Nessus. If it's not on Nessus and you're older, like me, not all of my baby vaccines are on there. So if your parents have records, you need to know those. And if you don't have records and you can't find your records, you do need to talk to your healthcare provider. That way they can determine the next steps for you. Are you in a high risk category? Do you need MMR now? That all of that will be discussed with your healthcare provider. Know your risks when you're traveling. So if you're going to travel somewhere, know if if measles is endemic there. And if you need to get the vaccination before you go, if you're traveling within the United States, be up to date on where the most recent outbreaks are or where all of the outbreaks are. But that way you can protect yourself. And then finally, know the signs and symptoms. That's why we went over them. That way you guys can, it will ring a bell if it starts happening to you or if you see it. And then also the final one, act fast. And that way we can reduce that transmission.
Jacki, Dr. Beecham here. I just want to really support that. And can I just put up a picture here?
Yes.
You just kind of see my screen. So the problem with measles is that it looks just like everything else, and it's a real challenge because initially it's cough, cold, respiratory stuff, and then it turns into maybe you see the white spots in the mouth, maybe you just start to see the rash. The challenge with measles is it loves us. It is super infectious. If you have a good exposure, you're likely to be infected if you're unvaccinated. And so that's a big problem in terms of its spread, but it also provides a little opportunity for us diagnostically because a lot of these, I remember thinking at the beginning of COVID, these symptoms are so nonspecific. How does anybody ever diagnose this? Then you're in the middle of a big outbreak and it's like, oh, I see this everywhere. Now I can't miss it. And I think measles is likely kind of the similar kind of thing. And so the first thing is to just have a high index of suspicion and listen to what the patient's telling you, because in my experience, they're going to give us a clue. Oh, gee, I was down visiting my friends in Texas and they have measles. Sometimes it's as obvious as that. And I am not above saying to people, have you been around anybody that is even talking about measles or thinks they might have it? Because often those people are going to have a clue because you start to see these symptoms pretty reliably within 72 hours. And let's say they are a travel case and they've come back. By that point, they may be getting some notification from their friends. Hey, you know what? We just got diagnosed with measles. And sometimes they're coming in with those symptoms. I would say contacting the health department is on the very first list of things to do. But Jacki, I would even say before that, you put people in a room and you close the door. That's the kind of isolation that can be effective, whether you're at a school setting or in the community or even in a clinic. With COVID initially, it was all this we got to find those patients and put them in a room. Any more of the recommendations are anybody who's sick, anybody who's you're concerned about, put them in a room, close the door. It at least gives you a minute to sort of figure out where do I stand. If you've got immunocompromised patients, those are the ones that we want in the really clean rooms anymore. It's, trying to protect the really vulnerable. And all your kind of general players, just put them in a room and close the door because we do consider this to be airborne. And, with COVID, it was always, well, is this contact? Is it's airborne? Maybe it's a little bit of both. Measles is airborne. This is the big one. It loves us. It moves around. So it can be infectious even for 2 hours in a room. So the other thing is if you're putting somebody in a room and closing the door and being like, this may be a measles case, we're calling the health department. The other piece is that part of our intervention is going to be doing some ring vaccination and doing some potential case finding and figuring out what's the ring and how do we vaccinate those people. So that's another question we're going to be asking you. Where was this person? Who else was around them? You know, if it turns out to be a real case, that identifying the ring becomes important, and your best opportunity to think about the ring is early on. You know, oh gee, they were in this class. And I would always say, if it does turn out to be a big case, you're going to be really glad that you put that person in a room and close the door, because every additional person who doesn't come in contact with them is somebody that you don't have to be chasing and worrying about for potentially up to 21 days with this thing. So if you're starting to get clues, if your spidey senses are tingling, gosh, this may be the real thing. It's, hey, while we figure this out, how about you come into this room and I'm putting my mask on and I'm walking you into the room and I'm closing the door behind you. That gives you a minute to kind of figure it out and have a low index of suspicion. And in my world, that means if you're kind of worried, take it seriously and give us a call at the health department, talk through it. We'll help you sort of figure out, is this, you know, a high risk case? Is it low risk? What do we do? The other thing I'd say is we're starting to already get calls. Hey, I'm hearing about this measles in the paper. Do I need to get another vaccine as an adult? Does my infant need to be getting a vaccine earlier than 1 year? And, you know, at the moment, we're not kind of veering from traditional recommendations about this, but that definitely changes if we start to see cases, because then it goes from routine protection to we're using the vaccine as also a prevention and specific control strategy. So those are some of the things that I want to say, but just hang in there, team, because we've seen this before with COVID. We sort of thought, oh, it'll never find us. We're in rural Nebraska. How could it possibly find us? And it found us in a big way. This could be the same thing. We know we have a lot of movement. People are going back and forth. Ask the questions. Do you know, have you been around anybody that you think might have measles? You know, high risk populations. Gee, you were at the homeschool convention last week and now your kids have this, and your friends who are also there saying that their kids are acting weird. Those are things that we are concerned about. And it's only by people being suspicious that we catch this stuff. So if you start to kind of get clues from the history, you know, if you're seeing kids who are unvaccinated and have these spots, those would be high risk groups to look at. Even if it's, hey, we're going to catch our breath a minute. Why don't you just stay in here and watch TV for a second, honey, while we close the door behind you and figure out where things are. You don't need to like raise the alarm 10 out of 10. But during the time that you're figuring things out initially, that's a good chance to have the patient not spreading anything further. Just keep them in a room and call us. We'll help you. Dr. Stein, we're so glad to see you in the role of the epidemiologist at the state. You know, it's a team effort, and some of it is just suspecting it. Once we diagnose a case, then there's going to be a whole lot of eyes on it. But it could be somebody in this room sees it first. And I've never seen it as a doc, because really after the vaccines became pretty widespread in the 60s, we haven't seen it. But you're going to get some clues somewhere. Don't ignore them. Jackie, what else do you want me to say in terms of measles stuff? Just hang in there, guys.
I think you covered most of it.
Okay. Well, I know that there's a lot of people on this call that have been through, you know, you've been there when this stuff goes south, and you know it happens sometimes, but we just gotta be prepared and do what we need to do, and know that the health department is going to support you if you start getting to that point. Jeremy, welcome to us from the beach. What are you doing?
Yeah, it feels better having that background since I'm in my office all the time, you know. Yeah, thank you, Dr. Beecham. And Dr. Stein, any closing comments as we're kind of getting ready to wrap up here?
The one last thing I wanted to say for our medical providers is that at this time, we are not deviating from CDC's vaccine recommendations. However, CDC currently recommends that if you're going to be traveling internationally, or if you know you have planned travel to an outbreak area, we can go ahead and implement an early dose of MMR in children that are 6 months to 11 months of age. That doesn't count as towards their 2 doses, but it is an early dose. And then for children who have had 1 dose but haven't, aren't traditionally at that 4 to 6 years of age where we would give the second dose, they can receive that second dose early as long as it's 28 days separated from the first. So those would only be in situations, again, if you're going international travel. There are many, many countries around the world right now experiencing very large measles outbreaks, more than we are. Or if you know you're traveling to an outbreak area and it can't be avoided.
All right, thank you, Dr. Stein. All right, Jackie, turn back to you.
So I do have just a couple slides. The last two are like if there's any questions that we would like to ask Dr. Stein, Dr. Beecham, or Aravind, or I'm probably going to defer to the smarter people in the room. No, I don't see any hands going up. See in the chat. Nicole asked in the comments, is there community education going out? So my next slide, I'll just move to it. So I did provide some resources. So where I got all my information is cdc.gov. So they have just measles information, and then they have measles outbreak information. So that measles outbreak information, I wanted everybody to make sure that they knew where that was, because it updates every Thursday, Friday-ish. And so it's a living, breathing thing, right? So this is a great page for you guys all to be checking every week. I check it every Friday just to see where the numbers are, see if we have new states or jurisdictions that are reporting. And then, just see the numbers, see if we have more deaths, things like that. So I wanted you guys to have both of those on there. Also, I got a lot of the information from the Nebraska Health Alert Network. So they send out health alerts. And if you're on my clinician group and whatnot, I send those out to you guys when I get them as well. And so that gives a lot of great information for clinicians and for travel. So I got a lot of my information from there as well. I wanted you all to have our leadership email. That way, if you have questions, concerns, you can email that. And then finally, NPHL, the guidance on testing for measles. Wanted you guys to be aware of that. They have a nice form that tells everything. You can check the boxes, and then that VPD form as well. I will be sending out the recording of this video. I will send out the slides, and then I will send out supporting documents. So any PDFs that we have community education that we've done before and that we have, and we are going to be putting a bunch out on social media as well. So a lot on measles, and then even just on skin rashes, because it's, a lot of people, if it's a rash, then they think measles, and, there are certain things that we want to look for. So just education. So we will have all those attached. So I'm sorry if you guys get like 6 attachments, but I want everybody to have everything. And if you don't see what you want and you need something else, please let me know. Just contact us. And if we don't have it between us and the Department of Health and Human Services, we'll get you one.
Darren said he had a question.
Yeah.
Yes, ma'am.
There he is.
Darren Lewis, Buffalo County Emergency Management Director. Good afternoon, everybody. Jeremy made a comment early on in his warm, welcoming statements that that measles had been eradicated back in 2002. So my question, twofold, I guess, is what's the definition of eradication when it comes to measles? And when was that eradication then not? What year was it determined that it was not eradicated in the United States? Because from 2000, statistically, what I'm seeing is that there's not ever not been a case of measles in the United States.
I think Aravind will be the best position to discuss that.
Thank you.
Thank you so much for bringing that, Darren. And it's so important. I'm so glad you brought this. It's a great opportunity for us to segue into this discussion. Technically, the word is not eradication. Measles has been eliminated from the United States, and we were declared as measles having been eliminated from the country in 2000, in the year 2000, so 25 years back. The definition of elimination means that as we've seen, I'm going to look at the survey properly so that I don't get myself wrong here, but there has to be an outbreak. The same outbreak has to last for one entire calendar year. And an outbreak is what they define an outbreak as 3 related cases. Right. So what's been happening in the last 25 years is that we've definitely detected a measles cases here. There's also been a death. I think that was in 2012 or 2013. But these are all imported cases that were not endemic, that were not really circulating out in the wild. There were cases that came into the country because of a variety of reasons. People who had foreign travel, people who are immigrants who came in from another country and who were not adequately vaccinated, or improperly vaccinated, or incompletely vaccinated. So there wasn't really like, for want of a better word, like a local reservoir, and there wasn't endemicity. But right now, what seems pretty clear from the cases right now is that we are in this era of endemicity. Measles is endemic to the United States. And that really means we have not eliminated it, or rather we eliminated it and it's come back. So no, we never eradicated measles, we eliminated it, and that ship has sailed. Thank you.
And thanks for that explanation, Dr. Menon. And Darren, that's a great question. We think about polio, another common childhood disease, or if we think about smallpox, those are things very similar in effect that from a local perspective, we don't see that. And we don't see that even in the United States. And so smallpox, we can say, has been eradicated, through global efforts. There's been no known smallpox cases. And polio is very close to being, if it hasn't already, I know there's some eradication, still some small flares here and there, but it comes to measles, unfortunately, like Dr. Mann, it's a technical definition, but for all intents and purposes, we haven't seen it in our communities, which is great. And we hope not to see it because it just like a lot of other common childhood diseases, these do have kind of a nasty tail to them. People do get hospitalized. You can die from this. So we don't like to be the fear mongers, but just like to give people reliable and current information.
Thank you, guys. Sorry, keep going.
I was going to say one other thing that we do really worry about with measles infection that is different from a lot of our other respiratory infections is even people that don't have serious illness develop. Measles specifically replicates in and destroys the body's memory immune cells. And so after you've had a natural infection with measles, essentially your immune system gets reset. Any infection that you had previously gained immunity against is now you don't have that protection anymore. And this is a huge problem in other parts of the world where we see much greater, childhood fatality rates because they then can be more susceptible to other infections after they've had measles. So we really encourage people not to try and gain natural immunity at this point, and the vaccine is safe and effective to prevent infections.
Thank you, Dr. Stein. That's, I think, something to note.
I'd just like to support that again. I know we hear some mixed messages in the media, this and that. What I think about these vaccines is every vaccine we have represents somebody else's pandemic that was totally devastating to them in its moment. And I think measles falls in this category. It's easy to poo-poo it. Oh, most kids don't get that sick, this and that. I hear the doc who's treating the measles case now has measles himself and is like proud of that. But, it's the kind of thing, we don't have to have these sorts of things. And I think this risk balance gets really wacky when we don't ever see these diseases and don't experience any of the bad effects of the disease and only see the vaccine. And this really, I think, drives people's feeling of hesitancy. Like, well, why do I take my risk with the vaccine when this thing isn't really around anyway? Well, we've now changed our risk and balance as a result of those kind of thoughts. And so now we are in a place where we're going to start to see more of we're going to get kicked a little bit more by this actual disease. And so, that's where it really is worth reinforcing just again, this is a safe and effective vaccine, and 2 doses is better than 1. And it really does keep kids from dying. And does it also keep you from getting kind of sick and you might get better anyway? Yeah, maybe. But, we give these vaccines because it was a big deal to somebody. And somebody's kid who was dying 100 years ago of this, you know, we now have an opportunity not to have that around, and people make their choices, but we have to respect the choices they make. We try to move people who are kind of in that hesitancy. I think that's really important. Just because people don't have this vaccine yet doesn't mean they're a hard no. They may be just reluctant, and this is something that can make them more likely to accept this safe intervention. And also, we just have to keep our eyes peeled because the story has changed a little bit. And eradication, elimination, well, we don't have any of those words anymore. We're about to be endemic. And that's really an unfortunate side effect of some of this stuff. But we play the cards that we've got, and this is the hand that we've got currently. So keep your eyes peeled because you may see it. Encourage your people to get vaccinated. And if and when we do see it, we're ready to go with plan B. So that's kind of where we stand. And everybody's got a role in this. So keep up the fight.
Thanks, Dr. Beecham. There was one other question in the chat, and it was from Jay Cornelius asking what countries are experiencing a high level of measles outbreak. And Dr. Stein went ahead and put a link in there. I'll make sure and share that with everybody as well. But Dr. Stein also wrote that this list CDC maintains and changes often. So it's best if you guys go to that link and look at it for yourself because it could change. So we'll include that in our information for you guys as well. So I don't want to keep anybody too much longer because we're at 1:04. So long story short, if you guys need us, you know where to find us. This slides, there's a bunch of emails and our contact information. So let us know. And if there's something you need specifically, let us know and we'll work with you to get you what you need. So everybody have a great day. Thank you, Dr. Stein. Thank you, Aravind. Thank you, Beecham, Dr. Beecham, and thank you, Jeremy. Everybody have a great day.
Thank you, Jacki.